TV kitambulisho.
All right, it is Friday, the 19th of March 2021. The United Republic of Tanzania and the East African region by extension continues to mourn a head of state, President John Pombe Magufuli, who according to reports succumbed to heart complications at a hospital in Dar es Salaam Wednesday evening. May the Lord rest his soul in peace. Now, as promised last Friday, today is the day when we delve deeper into cardiac conditions in children. And in studio with me is a pediatric cardiologist. I'll give her time to introduce herself, tell us who she is and where she comes from. Welcome.
Thank you so much, Elizabeth. My name is Dr. Gladys Njihia. I am a pediatric cardiologist working at the Mater Hospital, where we have a very vibrant pediatric cardiac clinic, and we do a lot of work in the pediatric cardiac field. I am one of we are a total of 5 pediatric cardiologists in the hospital who manage the children.
Welcome, and thank you so much for gracing our studios with your presence. Now, this is Around the Table show with me, Asasha Elizabeth, and due to the complexity of the subject, we had to narrow down to children. Now, let's get started. Now, Dr. Njihia, what is the burden of heart disease in children?
Heart disease in children, congenital heart disease in children is basically one of the most common congenital defects that children are born with. And when we say congenital, it's just a defect that a child is born with, that they acquire as they develop in their mother's womb. So the burden as of now is that about 2 to 3 children born in a total of about 1,000 live births will have a critical congenital heart disease. But the general figure is about 8 live births per 1,000 live births. So about 8 children in 1,000 will have a form of congenital heart disease.
All right, thank you.
Yes.
Now, are all problems in children, heart ailments, congenital?
Not really. It depends on the age group, but we do have congenital heart diseases, and these are the diseases that babies are born with, and I think defect is actually a better term. And then we have acquired. There are those heart conditions that are acquired for one reason or another. It could be an infection, a viral infection that affects the muscle of the heart and gives children something called cardiomyopathy. It could also be, a common one in Kenya is rheumatic heart disease, which is as a result of throat infections from the age of about 5 to 15 years.
Thank you. Now, what causes congenital heart disease, and can it be prevented?
Congenital heart diseases, 70% of the time we really do not know actually what causes them, but some of the known causes are sometimes genetics. So some form of congenital cardiac defects will be passed in a family because of genetic mutations or yes, so genetics is one of the things like Down syndrome. You have a genetic mutation that occurs in early, when the child is forming, really early in the first couple of days. And Down syndrome causes
during pregnancy.
During pregnancy, just after fertilization and the embryo has been formed. And Down syndrome, it's a syndrome which has many other things, but it really associated with congenital heart disease in about 50% of the cases. Other things are like diabetes in pregnancy. So diabetes, if not well controlled, predisposes the fetus to congenital heart disease. Some viral infections in a mother early in pregnancy, things like rubella. Rubella is actually something that can be vaccinated for every woman to prevent this in the child, because rubella in the mother may not be so aggressive, but in the unborn child they may have some significant cardiac defects, things like what we call pulmonary valve stenosis or patent ductus arteriosus, so that is really one of the causes. Other infections are like syphilis. Some other things are like medication. So I think, again, in pregnancy we have to be very careful about medication You should make sure whatever drugs one is taking, at least the obstetrician should okay them, because some drugs are associated with congenital heart defects.
Yeah, thank you so much. Now, you have mentioned rubella as one of the precursors of congenital heart disease. Who is at risk of getting a child with a congenital heart disease?
Who is at risk? So, one of the important things to note as well is that nutrition, the mother's nutrition is really key. So, if the pregnant woman should ensure she's really taking nutritious food. You know, we keep talking about folic acid supplementation, and because those things do avoid congenital defects in general. But like we had said, people at risk are someone with like diabetes. That needs to be controlled in pregnancy. It has to be really well managed. If there's a history of congenital heart disease in a family, that and someone is pregnant, that particular person in that family probably has a higher risk of getting a child with a congenital heart defect compared to the rest of the public or of the society, where people do not have that history of heart defects. And also, if you got some infection early in pregnancy, you're just certainly more predisposed to getting the heart defect.
Thank you. Now, what are the different congenital heart diseases? Please take us through them briefly.
So, to put it in simple terms, we usually call them, you may have a pink baby or blue babies. So, and I'll talk about the blue babies, and they can present very early, even within the first week of life, as very critical cyanotic heart disease. Blue babies, in medical terms, is basically cyanosis. And when we talk about cyanosis, what we are saying is that the child is not getting enough oxygen. Because, you know, blood gets to the lungs and it's oxygenated, and once it's oxygenated, then it's pink, you know, the patient will appear pink. So blue babies do not have enough blood in their body that is well oxygenated. And so some of those conditions, some will be picked early, you know, the critical ones, the ones we say they're critical, where basically there's something called transposition of the great vessels, where the great vessels of the heart, which are usually two, the aorta and the pulmonary artery, switch position. And so these children do not have enough blood that has oxygen going around the body. And then some also have like valve, the pulmonary artery that takes blood to the lungs may be narrow at some point, and therefore restricting flow to the lungs. And that again will cause the children to not have enough oxygen, and they may present with reduced oxygen as blue babies. And then some conditions, some very complex conditions, the blood, you know, generally in the body, blood with oxygen does not mix with blood without oxygen. Sure. Blood will go to the lungs, get oxygenated, go back to the left side of the heart and to the body, but there is no mixing. So in some defects, there's a lot of mixing between the oxygenated blood and deoxygenated blood. And as you can imagine, that will dilute the blood that is with oxygen and bring oxygen levels low. So those will also present as blue babies. Pink babies, generally, some may be picked early, some may not be picked early. It depends on the severity of the defect. Some defects are not so severe and may be picked as the child is growing, maybe because they had a respiratory tract infection, a cold, a flu, and went and someone listened to their heart and they had a mama. But pink babies, basically there are some simple holes which occur within the heart, or some connections, abnormal connections, that generally should not be there. But and some, if they present critically, it will be because they're in heart failure. You know, so some congenital heart disease can lead to congestive, it's called congestive cardiac failure, where they present with some difficulty in breathing, you know, they're not thriving, they don't gain weight, they're recurrently unwell, always being treated for pneumonia. So those are some of the more severe pink babies, and then there are the milder ones, like I said.
Now tell us briefly, tell us about other heart ailments or conditions in children apart from the congenital heart diseases. Okay, so
if it's not congenital, it's acquired. Acquired just means you've gotten it after you were born.
Okay.
And so some of the conditions, like I had mentioned before, we have like viral infections that can actually affect the cardiac muscles and weaken them. And that is called cardiomyopathy. And those babies, that will be acquired, and they will present in heart failure, basically. And some of the others, and I mean the most common in Kenya especially, is rheumatic heart disease, which is as a result of a throat infection that is not well managed, that eventually leads to the heart valves being infected, and they don't function well, because some valves may become very stenosed, so they do not open. You know, the valves in the heart act as basically they open and close, and they allow blood to flow in one direction. So with rheumatic heart disease, depending on the severity, some valves will allow backflow of the blood into a chamber that it should not go back to, because like I said, it flows in one direction. And if it's really serious, then they will be very tight, very stenosed, and they do not open. And some we treat medically, some patients will be managed medically based on their level of severity in terms of symptomatology. But some eventually will actually need surgical repair, open heart surgery, whether to repair a valve or even to replace the valve. Other conditions in children are also called arrhythmias. These are rhythm problems, because there's a way the heart beats in a very regular fashion. But some people, children and even adults, will have some abnormal rhythm that can be significant enough to cause quite severe symptoms, especially if the arrhythmia it's a rapid heart rate. You know, if your heart rate is beating about 200 beats per minute, the heart will not be able to sustain that for long, and so they can go into heart failure. And yes.
So can this rheumatic heart disease be prevented?
Yes, rheumatic heart disease can be prevented, because like I said, it's as a result of untreated throat infections. So if when a child gets a throat infection, and it really affects children between the age of 5 to 15, so when children get throat infections and and they're febrile, and you know, whenever they complain pain on swallowing, could be some tonsillitis, it's really important for that to be checked. And if it's a bacterial infection, it should be treated with antibiotics. Otherwise, if they keep getting this recurrent throat infections, sore throats that are not treated, eventually now they present in rheumatic heart disease. Even, first of all, it's rheumatic fever, where they present with joint pains, they may have some features of heart failure, and if that is not managed, eventually they have no severe rheumatic heart disease. So for babies, or for not babies, for children, usually they are teenagers or slightly they are older children who have had rheumatic fever, we tend to put them on a monthly injection. It's called benzathine penicillin, to prevent a recurrence of the throat infections, so as to protect the heart. So that is one of the ways we prevent progression to severe rheumatic heart disease.
All right. Now we are taking a brief break here, and we will be right back with more on cardiac conditions in children. Do stay tuned.
Capuchin TV, kitambulisho Katoliki.
Do you have a child or a friend doing their exams and whom you wish that we pray for? Contact us on 0717 424 866 and we shall do that for you.
Kipaimara ni sakramenti yenye kumpa Mkristu Roho Mtakatifu na ukamilifu wa mapaji yake 7, kumfanya Mkristu mkamilifu na kumfanya shahidi hodari wa Yesu Kristo mpaka kufa.
Kupata kipaimara kama Skiza Tune yako, tuma neno Skiza likifuatwa na nambari 738100272 kwa 811. Capuchin TV, kitambulisho Katoliki.
Welcome back, and thank you so much for keeping tabs with Around the Table show with me, Sasha Elizabeth. Now, before we went for a break, we had a discussion briefly on what congenital heart diseases are in children and some of other ailments, both congenital and acquired. And with me in studio is Dr. Gladys Njihia, a pediatric cardiologist, and we move on with our discussion. Welcome back to our second session, Doctor.
Thank you very much.
Now, what are some of the signs and symptoms of the congenital heart diseases in children?
Okay, so some of the signs and symptoms would be things like breathing difficulties in a baby, in a child. Just rapid breathing, and sometimes they have recurrent chest infections, recurrent coughs. Being recurrently treated for pneumonia. If a child has to be treated several times for a pneumonia process, then it's ideal for them to actually have an echocardiogram to rule out any congenital heart disease. And for the older ones, they present with fatigue on just exertion, on mild exertion. When you compare them to other children, they're getting tired faster than other children when they play. See, they'll play for a bit and then they sit down, depending on how severe the condition is. For babies as well, it's failure to grow, to add weight. They just don't add weight well compared to other children, and they stagnate. And so that should be a sign that we need to screen for 1, 2, 3. Another, sometimes they present mamas. It's really one of the key things in cardiology. A mama is just an abnormal heart sound because of turbulence within the heart. So some children will actually not have symptoms, especially if it's not severe. They may grow well, they may be so playful, active, they're not blue. Again, the blue baby, a parent can know that this child changes color when they're tired, so they can actually pick out that they have a blue baby. But some babies will just present with mamas, and it will be an incidental finding. They went to hospital to be checked for a cold, and someone listened to their chest, and they had an abnormal sound, and they sent them for an evaluation, and then we pick it from there.
So how early can these signs and symptoms be detected in a child?
So that depends on how severe the defect is. Like I said, there's some very severe congenital heart diseases that are picked within the first 3 days of life. Because a child is born and then they are just blue. Especially the cyanotic heart disease, they do not oxygenate well, no matter how much support they're given in a hospital setup. So those ones will present pretty early. Some also critical lesions will present with congestive cardiac failure. And when I say congestive cardiac failure, they basically present with difficulty in breathing. Difficulty in breathing is the most common thing. Sometimes they have swelling of the legs. They have an enlarged liver, but for a parent it will be difficult in breathing and difficult in feeding. Those may also present early. And for the less severe conditions, they could present even in adulthood, and some get to adulthood actually. You get a 60-year-old with a congenital heart disease.
Thank you so much. Now, how well can children with a congenital or acquired heart defects function? So
their functionality is again dependent on the severity of the lesion. Some function okay, there's no much difference between them and the other children, their physical activity. So for cardiology, we mostly look at the physical activity because it tells us how severe it is. So if you're getting tired very quickly, you walk up one flight of stairs and you're breathless, you could have a more significant lesion than someone who's able to go up 4 flights of stairs. If a child can play for 1 hour, 2 hours, it's probably not as bad as, and they have a heart lesion, it's not as severe. So their functionality is really dependent on the severity of the lesion. Some are so sick, they just will not leave the hospital. Some will not grow at all. They'll have delay in milestones, and those ones we have to intervene early. So it's really a spectrum in terms of their functionality.
All right. Now, there is a growing concern in the public about children or people who undergo surgical procedures to correct heart defects. Please tell us about does it in any way affect their lifespan after going through surgical procedures? Or it's just a myth?
I think it's a myth. Maybe for the public when they say cardiac surgery, you know, they don't realize it's a whole. There's a spectrum of diagnosis. There are so many different types of cardiac conditions that we operate the kids for, and they have different outcomes. Some are very simple, you know, something like an atrial septal defect. Once the surgery is done, that patient will be fine for the rest of their life. There should be no difference between them and any other child. So I think it's really a myth, and again it depends on the type of surgery and the type of heart defect, because there's some heart conditions we do what we call total repair, and there are some we do palliative surgical repairs. And for the palliative cases, definitely the functionality even after the surgical repair will not be normal. It will not be like a child who never had any problem, but it will be better than what they were. I mean, their quality of life is significantly improved, but not to maybe compare to other children what that would be. Those are for the palliative cases, but for cases we do complete and total repair, a majority do well, majority survive to adulthood, and we still follow up quite a number of adults.
All right.
Yeah.
All right. Now, what are some of the health practices that a parent can embrace or encourage a child to practice in order to be safe from both congenital or rather acquired heart ailments? Because congenital is a condition that they are born with, right?
Yes, you're born with. Congenital, you're born with. I mean, for a parent, for acquired, like we said, acquired, the ones you can do something about. Again, like I say, things like rheumatic heart disease, it's just really a sore throat. And if that is treated, if every time your child complains of a sore throat, you know, pain on swallowing and all this tonsillitis, if that is treated, then the parent will prevent rheumatic fever and rheumatic heart disease. But if that is ignored, or if we choose, you know, to go herbal, sometimes by the time the diagnosis is being made, it's quite advanced and severe. So for a parent, I would think that is really one of the main things they can do to prevent acquired, but some are not preventable. Like there's nothing you and me can do to prevent, only that we'll manage once the diagnosis is made.
So something about the oral hygiene or
oral hygiene
in children.
Yeah,
can that help prevent acquired heart defects like rheumatic heart disease? It would help for sure, because if you have good oral hygiene, you'd probably not have, you know, like food particles. I mean, that can cause dental caries and stuff like that. But it definitely helps. And for rheumatic heart disease, it's about overcrowding. You know, people, if you stay in a crowded place, there tend to be a lot of transmission of viral infections. It's about cultural practices. Because like in Kenya, we've actually identified that some parts of the country are more prone to rheumatic heart disease compared to other parts of the country. We don't yet have all the answers, but like a district, county like Bomet, we've gone there a couple of times, and they really have a high burden of rheumatic heart disease. So we wonder if it could be their cultural practices that, you know, kids are not just treated for sore throats. You know, we tend to assume itaisha. Okay, thank you. Now, heart ailments, both congenital and acquired, have an impact on families. Could you please tell us more about that?
So, heart disease is actually an expensive condition to manage, because it's not like an infection where you go just give an antibiotic. Especially if it's for rheumatic, if it's advanced and we need to do some surgical intervention. The thing with cardiac surgeries, they're very expensive because there's a whole team. There's a huge team involved to just care for that one baby. And the infrastructure, the equipment, you know, the ICU, the theater, the things needed to just make that one case successful is a lot of investment for a hospital. So they're very expensive procedures to undertake. And also because now in Kenya, I mean, I have to be grateful for NHIF because it does try to support the babies, partly, but again, most of the patients cannot afford still the additional extra that they have to put in. And so for some families, it's really a struggle. Yes, and that's why we do have the Matter Heart Fund, where we try to support children and their families, but again, it's a core share, a core pay kind of method. So they have to, some families are fully supported after the vetting. There's a whole process that goes on. But yeah, it's a very expensive thing to undertake. And sometimes some parents have to leave work, at least one parent. If a child is fully dependent on you as a parent, to take care for them because of the severity of the disease. Some also drop out of school because they're not able even to walk to school. So you can see it will also affect your education. You're always in hospital. Hospital bills are high. So it has a high impact on families.
Thank you. Now you have concentrated more on children because it is a broad and complex subject. But briefly tell us how is it challenging? How is it challenging to manage heart ailments in adults? In adults, or sometimes we do have children. We call them adults with congenital heart disease. Grown-ups with congenital heart disease. Okay, yeah.
So because we've been doing surgeries and now they're actually getting to grow. I think many years back, they really never used to reach adulthood because they were not managed properly. But now that we're doing all these interventions, all these surgeries, they're getting to grow to adulthood. And like I said, like for the people we do the palliative procedures, there's a lot of, they need to be integrated into the society, challenges with, for them it's about, can they be parents, can they get children, how viable is that? And we try counsel them on those things because those are just some of the challenges. And then now we get to see complications of repaired heart diseases in adulthood. And those are a bit challenging to manage as well.
Thank you so much, Dr. Gladys Njihia. Now, as we wind up, at what age or at what point should a parent take a child for congenital heart disease screening, and how best can we improve this kind of screening in the country?
I think for screening of congenital heart disease can even just be done in hospital when a child is born before they go home. It's just about checking their oxygen levels because by checking their oxygen levels, at least the cyanotic heart diseases will be picked because we said cyanotic is reduced oxygenation. So if you check their oxygen levels and they are low, then you would be prompted to ask for a cardiac evaluation for that particular child. Okay. I think that is one means that screening of that alone can make a huge difference in congenital heart disease. In other countries in Europe, they also screen. They do fetal echoes. It's called fetal echocardiography, where they screen all pregnant women for this congenital heart defects, and the severe ones are scheduled for repair soon after, within a week or two after delivery. So they're able to pick them before a child is born.
All right, we are about to end our discussion, so just your final remarks to the audience, the one who's watching you right now.
Okay, so congenital heart disease is actually one of the most common congenital defects in children. And the thing is, it can be screened and some conditions can be picked early. We encourage clinicians to even auscultate and to listen to the chest and to listen to the heart. And if a mama is hard, they should send the child immediately for cardiac evaluation. All right,
we are about to end our discussion, so just your final remarks to the audience, the one who's watching you right now.
Okay, so congenital heart disease is actually one of the most common congenital defects in children. And the thing is, it can be screened and some conditions can be picked early. We encourage clinicians to even auscultate and to listen to the chest and to listen to the heart. And if a mama is hard, they should send the child immediately for cardiac evaluation without really having to wait. And also to just be in the habit of checking oxygenation levels for all children when they come for vaccines, when they come for, at any point when a child is encountered in a hospital setup.
Now, thank you so much. That brings us to the end of our discussion on congenital heart conditions in children. And that was Dr. Gladys Njihia from Mater Misericordia Hospital, a pediatric cardiologist. My name is Sasha Elizabeth. Keep your questions coming and we'll be sure to find another day to give you more details and to respond to your questions. Thank you so much for making time for this show and see you next time. My name is Sasha Elizabeth. And I would like to thank the entire crew, the camera persons, Alan and Eva, Felix, Juma, our visual mixer, Cherubor, and our transmission person, Peter Mwangi. Goodbye, see you next time.